Good morning and good afternoon. This is Anil Shankar. I'm an attorney with Foley and Lardner's healthcare practice, and I would like to welcome you all to our webinar discussing the future of Medicaid managed care. Got a long agenda, so I'll just jump right into it. Today we've got three speakers and myself as the moderator. Our first speaker is a guest. His name is Steve Schramm. He's the managing director and founder of Optimus, a strategy and actuarial consulting firm that is dedicated to reforming the way healthcare services are delivered in publicly and privately sponsored healthcare programs. From Foley, we've got Diane Ung, a partner and member of the healthcare practice. Her practice focuses on federal and state healthcare legislation and payment issues arising under government programs such as Medicare and Medicaid. Her experience includes regulatory, legislative, healthcare, and business matters for public agency clients, and structuring Medicaid financing for safety net providers in the context of disproportionate share payment programs under federal Medicaid demonstrations authorized under Section 1115. Also from Foley, we have Mark Waxman, a healthcare lawyer here. He's the former chair of the healthcare industry team, and his practice focuses on transactional, regulatory, and contractual issues for-profit and not-for-profit providers and payers. Before we get started in the program, I'd like to go over a few housekeeping tips. Today's program will run for 60 minutes. We will apply for one general CLE credit for today's program. For those of you interested in obtaining CLE, please listen carefully for the code, and when we ask the poll questions, please enter that code in order to get credit. All New York and New Jersey and Kansas attendees applying for CLE credit must fill out the attorney affirmation form, which can be found in the resource list widget on your screen. Electronic questions can be submitted throughout the broadcast by clicking on the Q&A tab at the bottom of your screen. Time permitting, we will answer your questions at the end of the broadcast, or else we'll follow up with you following the presentation. Well, let's get started. So as most of you know by now, on June 1st, CMS issued a notice of proposed rulemaking that outlined a comprehensive update to the Medicaid managed care regulations. The rule proposed to revise and recast the entirety of the part of the Medicaid regulations that addresses Medicaid managed care organizations. And as such, the proposed rule represents a comprehensive attempt to modernize and restate the legal landscape surrounding Medicaid managed care. So as you might expect from such a comprehensive rule, there are many areas where stakeholders, including providers, plans, states, actuaries, and beneficiaries, would be interested in reviewing the changes, and they would wish to submit comments on the proposed rule. For this presentation, we have selected 4 key areas where we think the proposed rule merits a deeper dive. You can see them on your screen. The first will be a discussion of the medical loss ratio. The second will be the updates to the process and requirements for the development of capitation rates, including new language around what it means for capitation rates to be actuarially sound. Third, we're going to discuss the new regulatory language that would prohibit the state from directing payments from plans to providers. And finally, we're going to discuss the new authority that's been proposed for treating patients in an IMD or Institute for Mental Disease, or that would allow plans to provide alternative services to those normally covered by the Medicaid program. So the first topic here is the MLR. I'm going to start with a brief summary of the changes that are proposed by the notice of proposed rulemaking, and then we'll open it up to our experts to have a discussion about potential implications of the proposal and the issues stakeholders should be concerned with. So the proposed rule proposes new requirements for Medicaid plans throughout the country to report to their state the medical loss ratio, or MLR. This would begin with rate years beginning in 2017. So the requirements to report must follow a format that is specified in the proposed rule. The format is on your screen. It's the MLR is equal to the numerator is your incurred claims expenditures, plus the amount expended for activities that prove healthcare quality, plus the amount expended for program and integrity efforts, and then the denominator is your adjusted premium revenues, which is your premium revenues reduced by certain amounts for taxes and other deductible revenues. As you might guess, each of these individual terms is further defined in the rule, and in many cases the definitions are cross-refer you to the MLR provisions that apply to commercial plans, and CMS's stated goal was to generate some consistency between the Medicaid program and the commercial marketplace. In addition to reporting the MLR each year, plans would be required to submit expenditure data, claims data, and other financial information to the state. And while these reporting requirements would be mandatory, the proposed rule does not mandate a specific penalty for failure to meet the 85% MLR. Instead, states would have discretion to determine whether to require plans to remit funds to the state if the MLR is not met. However, if the state does impose a minimum MLR, it must be at least 85%. So while the rule gives states discretion to determine whether there would be a remittance required, the proposed rule would impose a more indirect consequence for any plan that does not meet their MLR, and that is that in the proposals for what would be considered actuarially sound, actuaries in the states are required to consider the MLR when developing the rates and to meet the standard that the rate submitted to CMS for approval has to be such that the plan could reasonably achieve an MLR standard of at least 85%. And in the preamble of the proposed rule, CMS did express an indication that, or an expectation that a plan's historical performance would impact its future capitation rates. So with that brief summary, I'll open it up for some questions. The first one is for you, Steve. As our actuary on the call today, I wanted to get your thoughts on the MLR requirement. Do you think that the incorporation of the MLR to Medicaid is appropriate, and how do you see the requirement playing out in terms of plan finances?
Thanks, Anil. One of the things that is important for the states and the MCOs to think about as they're reviewing this and considering submitting comments is there's no real magic to that 85% figure. And so as a result, if you have a program or a plan that needs a standard to be different than that 85%, we really think that would be an appropriate comment to be submitted. In Medicaid, you have significantly different levels of capitation and therefore non-medical load. And as a result, I think you could make an argument, and we would suggest people submit comments supporting why an MLR standard different than 85% should be considered. And it really needs to get at the goal of this MLR standard from CMS's perspective is to make sure that they're getting good value for medical care, but it still needs to be adjusted.
Great, thank you. And Diane, I also noticed in the proposed rule that some of the requirements related to reporting of data seem to mark a change in the level of federal oversight of what plans are doing with their money. Do you view that as a significant change?
Well, as a first matter, under Medicaid structure, it's not so much a federal oversight of the plan's expenditure, but rather it's an oversight of the state's expenditures. Because as we know, federal financial participation, or FFP, that's made with respect to what are a state valid medical assistance expenditure. So in the context of Medicaid managed care, the focus should be on the state's payments to the MCO, the PIP, the POP, the managed care entity, essentially. Now, one of CMS's policy rationales for these various MLR requirements is that it is to ensure what it says are the responsible fiscal stewardship of Medicaid expenditures. And here, CMS is saying that the rates which are actuarially sound, Those ensure that the capitation payments will cover reasonable, appropriate, and attainable costs in providing the covered services to the enrollees. So in other words, the costs that are not reasonable, not appropriate, etc., should not be included in the development of the rates. And this would appear to be a shift in focus now on what a plan does, on the plan expenditures, with these various MLR reporting requirements that are designed to examine how those funds are expended by the plan. And that naturally leads one to think a plan's payments to providers will be eventually subject to CMS oversight. Now, I would juxtapose this with CMS's prior stance taken in the 2002 rulemaking that where it said that the CMS does not regulate the payment rates between MCOs and providers. It would seem that once a plan starts reporting expenditures for purposes of the MLR, will it eventually have to justify the level of payments it's making to providers? You know, it could go either way. Are rates to providers too low to assure access? Or, you know, would CMS consider the rates unreasonably high? And how would you even evaluate that? You know, questions surrounding whether the various existing payment limits in the fee-for-service context would start becoming applicable on providers in the managed care context.
Thank you. Yeah, so let's go back to Steve. I think one of the biggest questions for stakeholders is to get a sense of how the MLR requirements will impact plan rates. As I mentioned on the previous slide, there is that requirement for actuaries to take into consideration the MLR when they're developing rates. Can you shed any light on how that process would work?
Sure. This is a really interesting question. If you look at the plain language summary, right around page 44 and 45 of the document, it talks about the state using the MLR in its rate development. But one of the interesting things is it doesn't require that the state incorporate a recoupment factor. And so what that does then is it gives a little bit of flexibility for the state's actuary to start thinking about how am I going to incorporate this MLR information, because I don't necessarily have to formally recoup the money. I have some potential leeway or judgment. Where it's a little unclear, and I think this would be an appropriate place for comments or questions to be submitted, is if you think about the way the MLR is calculated, it is a ratio. So the actuary will have to incorporate not only the adequacy of the premium, but as Diane said, also the appropriateness of the cost. And I think states actuaries and health plan actuaries would need a little bit more guidance from CMS on what they mean by incorporating that or considering that in the process. We think what it basically does is it, for plans that make significant returns, it's going to force the state's actuaries to reduce out-year rates compared to what they would have been. It's not clear, though, for plans that have cost structures that go above how exactly it would be incorporated. So I think those are valid comments that the state's actuaries and the MCO's actuaries submit in terms of the impact on the development of cap rates.
Great. I think the flip side of that question about how the MLR will impact plans is you know, how would it impact providers? And Mark, do you have any insights on whether the MLR would lead to increased payments to providers?
I'm not sure they lead to increased payments or decreased payments sort of in a vacuum, but let's take a step back for a moment. First, I'm not sure we mentioned it, but if you're going to file comments, July 27 is the date, and so that gives you some time to move through these 651 pages of material and decide what's most important to you. Second, this is obviously not the first time that the federal government has, if you will, legislated MLR limits. Most providers' plans are familiar, if not specifically, at least in a general way, with the application of the limits to the Medicare employer and exchange plans. So we're not writing on a completely blank template. In fact, many of the definitions that appear here as part of the MLR standards are exactly the same as in those other settings, albeit they may be applied differently. I also think we recognize that the responsibility for MLR compliance is on the plans, and that responsibility starts with the state's obligation through its contracts, which start on and after January 1, 2017, with the plans to report the MLR in accordance with these sections. And to the extent you've got multi-year contracts that don't start in 17, then you have to calculate and report an MLR for whatever rating period begins in 17. When the initial MLR went into effect, there were a variety of definitional fights that impacted the MLR ratio and in turn contracting. I think in this space we continue to see issues with respect to which administrative service costs are properly characterized as non-claims costs and which are really involved in quality improving activities. I'm not sure that the precision that one might like around that definition is complete. Where I think it affects plan provider relationships in particular is if you have been in sort of downstream in the middle of a year and all of a sudden the plan realizes that, gee whiz, it's not paying out enough money. Because the MLR can be over 85%, you don't have a problem if there's too much. You have a problem if there's too little, and people ask, well, can you retroactively affect contracts between plans and providers? And I think historically we've looked at it and had concerns about retroactive adjustment to initial contracts as opposed to terminations and new contracts going forward. I think a retroactive refit of a contract may be inconsistent with the eligible managed care or organization safe harbor in 42 CFR 1001.952T. Also raises questions with respect to engaging in practices which are a subterfuge to avoid the MLR reporting requirements, which can give rise to False Claims Act types of activity. If you have a problem, better to end a contract or complete the year. It's not the worst thing in the world to pay money to consumers after all. There are also some provider-payer initiative provisions that one might look at found in 438.6. Those are not new necessarily, but one might pay attention to them, providing some limitations on capitation payments that are going to go out from the state to the plans and in turn downstream from there. There's also a requirement that physician incentive plan compliance under 42 CFR 422.208, 422.210 continue to be adhered to. And one interesting provision, which I'm not sure everyone has paid a lot of attention to in this context, which has been there in 438.60, which is actually a prohibition on side payments, that the state agency must ensure no payment is paid to a network provider other than by, in essence, a plan for services covered under the contract, unless they're specifically required to be paid by the state. Side payments sometimes have existed in the past. People should be cognizant that one needs to be careful about side payments under the provisions of 438.60. Anil, back to you.
Thanks, Mark. Did you want to say anything about the network adequacy, or maybe looking at it from a larger perspective, not just the MLR, but are there other provisions in the rule here that you think will have a material impact on plan provider, or other than the one you just covered?
Listening to the prior comments, and you think about the context of oversight, and the rules with respect to what the state must report that we'll talk about in terms of actuarial soundness, the MLR, and then the network adequacy standards, there is a tension here between the degree that the feds are going to regulate the states and the desire to allow the states freedom to determine what it is they want to do to run their Medicaid programs. Clearly, this regulation, draws the line in a certain place where there's not, I think as Diane mentioned, specific rate regulation, but there's a lot more regulatory framework over what the feds will look at as part of the contracting process with the state. This same tension plays out around the network adequacy issues. So if you look at 438-206, 438-207, dealing both with availability of services and assurances of adequate capacity in services, you'll see that there are requirements with respect to timely access, requirements with respect to access to women's health specialists, requirements with respect to sort of sufficiency in a variety of ways, requirements with respect to provision of second opinions, out-of-network provider requirements, ensuring the cost no greater than it would be if the services were furnished within the network. Yet there's no specific rule that says, for example, the network adequacy requirement must be ability to get to every kind of specialist within blank minutes or within Y miles and the like. So you see sort of an increasing tightening, and to the extent that providers are able to make the case that the state is not current in its oversight, that's a fair comment to make. Some states have moved further in terms of reporting other than an annual basis as required on 438-207C. Some lawsuits have moved even further than that in terms of what is and isn't required for network adequacy. I think providers are concerned that without at least baselines, the state may have too much freedom in many ways around narrow networks and the like given to the plans, and the plans, of course, are concerned that they'd be able to have some leverage in the market. So we're going to see this tension continue to play out until there are fixed rules with enforcement mechanisms in place.
All right, thanks, Mark. There's a lot more we could talk about. Medical loss ratio, we need to move along to the rate development. So the proposed rule represents really the first major update to the requirements around rate development in the concept of actuarial soundness since the current rules were issued 13 years ago. Steve, maybe you could walk us through what you think are some of the 3 or 4 most interesting or important changes.
Sure, thanks. And just a note to the people listening in, don't think that the commentary on this actuarial soundness should be limited to just actuaries. I'm not a credentialed actuary. I lead an actuarial and strategy consulting firm, and I've worked with my team. A lot of this actuarial soundness impacts areas beyond traditional rate setting, so don't be intimidated in not submitting questions. I'm going to go through this slide and just hit each one of these 4 areas at a high level, and then I'll talk on the next slide at a little more detail. The first one is a shift. Previously in the past, CMS has allowed actuaries to certify to rate ranges. On page 84 of the plain language summary, it talks about a shift to requiring the state's actuaries to certify to actual rates paid at the rate cell level to a contracted MCO. We'll talk about the potential impact of that, and there's some late-breaking information on that based on last week's Society of Actuaries meeting. The second area is that the rates be based on encounter data and actually specifies a time period. This language is starting around page 90, and we can talk about the impact of that on the rate setting requirement. The third major change that we're talking about today are asymmetrical risk corridors. The key here is that risk sharing can be for profit or loss. And when I get a little more detail, I'll talk about the discussion that starts on page 93 of the plain language summary. Then the last area is the CMS requirement for approval of the rate certification and their ability to withhold dollars. That language starts around page 102. In terms of a more detailed conversation about each one of these, the shift of the certification to individual plan rates would be a dramatic change and would, we think, severely limit not only the health plan's ability to be creative, but also the state's actuaries' ability to meet their own actuarial standards. So this was actually raised last week at the Society of Actuaries Health meeting in Atlanta. Very pointed question given to CMS, and their response back was, we think there needs to be a change. That's not the interpretation that we were intending. We think rate ranges still make sense and will still be allowable. We just need more information on the justification for why certain rates are paid. And so I think the comments still need to come to focus on the need for states to have the ability to be flexible when it comes to the use of rate ranges and the like. The next area, the encounter data, look, this one, it really is just codifying a direction that CMS has been going for the last couple of years. And from our perspective, I think you need to recognize that this has been a direction CMS is going and will continue to go. I think where appropriate comments could come in are really getting at, for a startup program or a new managed care program, what will be the phase-in for the requirement of encounter data? And what are appropriate levels for actuaries still being able to do the necessary adjustments? The third area, the asymmetric risk corridors, this actually provides a tremendous amount of flexibility, but I wouldn't think of this in a vacuum. Look at it in terms of the opportunity to use this to your advantage if I'm a state or if I'm a health plan's actuary when it comes to coupling this with the medical loss ratio. If you think about it, the concern that's always been raised about medical loss ratios is that it removes the ability of a health plan to build its reserves by having good financial years. If you have to return that money, you've lost some of the ability to balance out your bad years with good years. And so you may want to think about specific examples of asymmetric risk corridors that are focused on very little upside risk sharing on the profit side, but are very focused on downside risk sharing on the loss side. The last piece that I think is really important is starting on page 102, this is one of the few areas where CMS in this proposed rule goes to great lengths to talk about its statutory authority to impose this new standard for approval of the rate certification. And they cite similar authority that they use for contract approval. The reason this is important is, in the past, if you had an actuary submit a rate certification, CMS had very little true authority to deny the rates. That's no longer the case. They actually have the ability to say your rates are not approved, and potentially later on in the document they talk about the ability to withhold FFP. So, Anil, I think there's a lot of significant changes that should engender comments from our audience.
Great. Steve, do you have a comment on how, if these changes are all finalized as they're proposed, do you see the rate development process taking a significantly longer time than it currently does? Would states have to start planning far in advance for their rate?
I think that's a great question, and from the feedback that we've received from the states that we work with as well as the health plans, this is going to require significantly more documentation. So I think part of the commentary needs to be not only the time that's going to be necessary, but also the resources on both the state and the MCO side.
Right. Okay. Now this question is for Mark and Diane. I'll ask Diane first. Which state policies do you think would have to change if the NPRM is finalized?
Well, Steve sort of alluded to the effect on states' creativity to use the rates to compensate providers in various ways, and one of these is what has been referred to in the preamble as the rate range payments, and these are payments that are being explicitly targeted here. The rate ranges where the states have often certified like both a lower bound and an upper bound of their capitation rates, and they therefore, after they receive the certification, they receive CMS approval of the rates anywhere within the range. Subsequently, the rates to plans are modified upwards from the low end towards an amount up to the higher bound of the rates. Here there could be a variety of reasons, policy reasons for states to do this. For example, a state may find that payments to the plans towards the upper bound are necessary to ensure the sufficiency of plan payments to providers and to maintain access to certain specialized services. And as Steve described under the proposed rule, the certification could only be made to the specific rates that are contained in the contract. So here now, the states cannot certify the range should the proposed rules be enacted. When you read the preamble, the ability for states to make subsequent rate adjustments, as Mark described earlier, those would seem limited under the proposed rule, although this could use some clarification on whether and to what extent a so-called retroactive adjustment may be acceptable. The concept of a rate range is then just relegated to use as a negotiating tool as opposed to a real vehicle that could enable states to flexibly achieve their own state-specific goals. The other area that could be affected is what is referred to as cross-subsidization. There are proposed provisions that the rate differences according to covered populations must not be based on differences in the FMAP. And here what we're really talking about are the newly eligible Medicaid population where there is enhanced federal matching, currently 100%. Phasing down slowly to 90%. Now, presumably, that would be a problem if the FMAP was the sole reason for the differences, but perhaps that should be clarified and request for clarification in the comments. And the rates must be specific to payments for each rate cell. CMS statements that payments from one rate cell must not cross-subsidize or be cross-subsidized by payments for any other rate cell. Now, we read this to apply when the rates are being developed and not with respect to a plan when it makes its service expenditures.
Great, Mark. What do you see as the outcome of the rate development changes?
Again, there are things that the feds are saying that we want to make sure that you do. And there are things that have existed that continue to exist where the feds are saying this is what you can do. In the first part, we heard Steve use the word flexible. I would add flexible but honest. We heard Diane talk about state creativity. I guess that's another way of saying flexible but honest. The rules with respect to actuarial sound capitation rates are getting tighter. Maybe that's from the experience of a number of states around the country, but when you have to be specific for each rate cell under a contract, as Diane said, when you cannot cross-subsidize on rate cells, whether you need to provide whatever additional data that CMS says they need to do the analysis, as part of the requirements when you need to ensure that the data is developed from actual experience from the Medicaid population, which is obviously something looking backward towards actual experience, and some rules with respect to what needs to be looked at on the non-benefit component of the rate, or the reasonable expenses, which, profit margin, cost of capital, other operational costs, and to have detailed findings across all of that. It says that the feds are really going to force the states to be much more transparent, if not rigorous, in what it is that they do. At the same time, the delivery system and provider payment initiatives continue to exist where the state can require the plans to implement value-based purchasing models for provider reimbursement, P for P, bundles, valuing outcomes over volume. The state can require multi-payer delivery system reform or performance improvement initiatives, as some have already. They can require minimum fee schedules for all providers or require uniform dollar percentage increases for all providers that perform a particular service under the contract. So again, a little bit of tension here between we're really going to pay attention to what you do, you need to be a lot more transparent, but we're going to give you some ability to move in directions that we'd like to see, which is some of this other type of delivery system activity.
Yeah, great. Thanks, Mark. We will be talking a little bit about some of that tension in the next section as well. But before we get there, we wanted to point out one of the other features of the law. Steve talked about how CMS is now requiring approval of the rates in a more robust fashion than they have in the past. But there's also a related provision that allows CMS the authority to defer or disallow parts of rates. That would be disallowing the FFP for a portion of a capitation rate while approving the remainder of the capitation rate. So Diane, do you see this as a big increase in CMS leverage vis-a-vis the states?
Well, currently the approach is an all or nothing for CMS rate approvals. The state capitation expenditures, those are subject to meeting the various requirements under 1903 M2A. And among other requirements, it includes the requirements that the rates are actuarially sound and the Secretary approves the contract. If there is any deficiency in the state's compliance with those requirements, none of the payments under the contract would be eligible for FFP. And here in the notice of proposed rulemaking, CMS is saying that the penalty may be disproportionate. So now the agency wants to reinterpret 1903M to allow it to selectively defer or disallow FFP for portions of the rate based on compliance with the requirements on a service-by-service basis. Now, we're not sure that's necessarily a good thing. Just setting aside whether you can even isolate the problem and portion of a rate that's affected on a service-specific basis, presumably, for example, there could be a question or an issue with an assumption relating to a particular service. Well, what standard are we going to be applying here? Will plan payments to providers be questioned? We talked about that earlier. And I'm even wondering what, how an appeal of this would go, and what would be the basis for the deferral. Is it going to get down to my actuary said this and yours said that? So really, the undesirable outcome would be that this could just basically slow down the rate and contract approval process, potentially causing disincentives to resolve the issues which would essentially be tabled. Now, this could be a potentially powerful tool.
Thanks, Diane. We're running a little bit behind time, so we're going to move on to the next section. So there are new provisions in the proposed rule as new language that would prohibit states from directing a plan's expenditures to a provider. Mark just mentioned some of the flexibility that they did provide and some exceptions. But each of those exceptions would require CMS pre-approval. So before we talk about the exceptions, I want to spend just a few minutes talking about the basic prohibition, which says that states may not direct a plan's expenditures to a provider. And now CMS says this is a long-standing policy in the preamble, but there has been some speculation that maybe it isn't, that maybe it seems to be an expansion of the current policy. So Diane, maybe you could articulate what CMS's position is in terms of prohibiting plan expenditures.
Well, the construct is based on two current regulatory provisions. One at currently 438.6C4. That provides that the state's cap payment is based only on the cost of state plan services to be provided under this contract with the managed care entity to beneficiaries. And then the second provision is that the state must ensure that it makes no payments to a provider for service covered under that contract other than payment to the managed care entity. And that's the rule Mark alluded to earlier as a prohibition on side payments at 438.60. There are some exceptions to this, for instance, the DISH payments and F2HC wraparound payments. So from these provisions, CMS is saying that the plan, as the risk-bearing entity, must have the ability to fully utilize the payments received under the contract to deliver the services. So in short, what that means is the plans assume responsibility for the provision of services and is taking payment at risk, so therefore the state cannot then direct the plan as to how to purchase and provide the services. Now, we do know that CMS currently prohibits clear pass-through arrangements, and this seems to build on that. And what is unclear here, really, is the meaning of directing payments by the state.
Yeah, that does seem to be the million-dollar question. As you mentioned, CMS does have a long-standing prohibition on there's clear pass-through arrangements where the state is determining both the recipient of a payment made by the plan and the amount of the payment. But it's not clear to me from just reading the rule, and it's something that could be clarified, or hopefully will be clarified in the final rule, is whether that same policy would still apply or whether it was something broader. Many states have arrangements in which they will direct plans or have include provisions in the plan contracts or in state law that say plans must expend a portion of their capitation rate on, for example, hospital services. Or they may say you've got to pay these particular designated safety net providers at levels that are at least above a minimum threshold. In the past, those arrangements have not, to my mind, directly implicated CMS's policy, which is to prohibit clear pass-through arrangements, because the plan still has some discretion to determine how much they pay or which hospitals would get which money and so forth. But now we just have a regulation that says states may not direct the payments, and it's not clear at all from just reading the preamble or the rule just what definition of direction will apply.
Yeah, and arguably CMS would no longer need to cobble together an argument that the state is acting contrary to this concept of a risk payment or is effectively paying providers on its own. So you're right, the question would become, the meaning of the word direct.
Yeah, the other aspect of the proposed rule that has led some folks to believe the prohibition on directing planned expenditures that's in the new regulation or the proposed regulation is broader than current policy is just the level of detail that's included in the exceptions to that policy. So there is the general prohibition, and then there's very narrowly circumscribed exception authority, each of which would require CMS approval. And CMS would only be able to approve models that fall into one of the three buckets you see on the screen. They have to either be a value-based purchasing model for provider reimbursement, or it has to be a state requirement for plans to participate in a multi-payer delivery system reform or performance improvement initiative, or it could be a state-mandated minimum fee schedule or a uniform dollar increase for all providers of a service. And in addition to falling within one of those three categories, there are additional criteria that have to be met. The proposed arrangement that is directed by the state would have to be based on utilization and delivery of services. It would have to direct expenditures equally using the same terms of performance for public and private providers of the same service. Would be expected to advance at least one goal or objective of the state quality strategy and have an evaluation plan to determine whether that goal or objective is being advanced. The arrangement could not be conditioned on IGT agreements, and the arrangement could not be renewed automatically. In addition, for the value-based purchasing or multi-payer delivery system initiative, the same metrics and terms of performance would have to be used for both public and private providers. And in addition, the state would be prohibited from recouping any unspent incentive payments. The plan would have to be able to retain those amounts. So, I mean, in the preamble, when they're describing this new policy, CMS articulated two goals that it was trying to balance. First it said that it wants plans to be able to fully utilize their capitation payments for the delivery of services. But on the other hand, they also want to encourage states to partner with plans to achieve delivery system and payment reform. And so this list of exceptions seems to strike a balance between those two goals. I mean, to my mind, it's fairly restrictive on what the flexibility the state would have to establish these arrangements. But Diane, I'm trying to get a sense, what do you think of the balance CMS has struck?
Well, it certainly reflects a very comprehensive vision of what CMS wants. But many states, they really have arrangements that could fall outside these exceptions. Absent a waiver, for instance, the rule could restrict a state's ability to pursue its own policy goals. Its own policy goals, its own objectives on service delivery and access to the state that are outside of these prescriptive exceptions. For example, you have historical Medicaid providers, and Medicaid has served as a key source of revenue to this safety net. These providers have served the Medicaid population, other low-income groups, and Medicaid revenue sustains their ability to continue to provide critical access to services and specialty services, for instance. So there's, given that there's unlikely to be a lot of overlap of these types of providers when you go across different coverage, from Medicaid to Medicare plans to plans on the exchange, it's really important source of revenue for them. So if the rate from which these payments are made, if they already meet the actuarial soundness requirements, it's unclear really why CMS would seek to prohibit these special arrangements when done through managed care plans. I would say, aside from its justification and adverse impact, it's really unclear how these requirements would be applied. For example, how are the service types and provider types defined? Could children's hospitals be considered a separate provider type, for instance? How about trauma services? Is that considered a separate service type? Contrast that with the broader categories in the state plan: hospitals, inpatient, outpatient services.
Right. Yeah, the one thing I would add, Diane, is that on a recent webinar that CMS held, they did link this new authority to arrangements that states may have developed to replace fee-for-service UPL payments, and they said that these restrictions would potentially be applicable to those arrangements. So that does seem to be in CMS's mind, that they're looking more closely at the ways in which states are mandating supplemental payments through plans and want them to meet these specific criteria in order to continue. So this could have a far-reaching implications for those providers who rely on those payments. All right, well, the last area we wanted to spend some time on was on the proposed language in the proposed rule about the IMD exclusion and the ability of plans to offer services that are not covered by the state Medicaid program on a fee-for-service basis. So in the proposed rule, there is language that would expressly allow plans to receive capitation rates for individuals who are admitted for a short-term stay in an IMD, and a short-term stay is defined as less than 15 days during a specific month. Your stay could overlap on 2 months, but as long as it's less than 15 days in 1 month, it qualifies as a short stay. And this is significant because there has been a very long-standing statutory prohibition that says the Medicaid program, federal financial participation, is not available for services provided to adults who are resident in an IMD who are between the ages of 21 and 64. So the language in the proposed rule would carve out a very significant exception to this policy by allowing coverage of those services that would otherwise not be allowable Medicaid services when done through managed care. So Diane, maybe you can articulate the legal basis or CMS's proposed legal basis for this flexibility?
Well, CMS goes to great lengths to base this on a managed care entity's historical flexibility, there's that word again, under their risk contracts to provide alternative services or services in alternative settings. And these would be in lieu of the services and settings that are actually covered under the Medicaid state plan. So they're casting this particular proposed rule as a clarification of a plan's flexibility to provide inpatient services in an IMD that are in lieu of providing the services in a state plan covered setting. There's language in the preamble that states that the contract between the state and the plan, it can't require the plan to use IMD facilities. However, it's unclear whether the contract can just require that alternative services should be made available without, of course, requiring the beneficiaries to accept them. It's also unclear whether this flexibility extends to PIPs that are not paid on a capitated basis.
That's true. All right, well, what's essentially very exciting about CMS's discussion of the IMD exclusion in the proposed rule is that it didn't seem to be cabined just to IMD services. There's a pretty lengthy discussion in the preamble of the ability of plans to cover alternative services in lieu of covered Medicaid services. So Diane, what is the extent of that authority, and to what extent can plans offer these alternative services that would not otherwise be covered by the Medicaid program?
Yeah, well, again, it goes back to the position of the entity's historical flexibility. Now, the current regulations provide that a managed care contract may cover services that are in addition to those covered under the state plan, so long as the costs of the additional services are not included in developing the rates. And that provision is currently at 438.6E. Now, this principle could be extended, and it may well have been, but it's really unclear how far as far as the other types of additional services go. Sobering centers, short-term crisis, residential services, housing, maybe social services. I would say that the big limitation here is the extent to which the alternative services can be considered in the capitation rates as a so-called proxy for state plan services. When that original rule was proposed in 2002, people got overly excited, thinking that the rates could directly include such costs.
Steve, do you have any comments to that? How would an actuary, if a plan has a program in which they're offering an alternative, maybe an IMD, they're covering stays in an IMD, or they're covering telemedicine, or they're covering social supports or housing, and those alternative services are in effect reducing the utilization of what are the covered state plan services by avoiding hospitalizations or so forth. How would an actuary account for those effects in the development of rates?
Well, I think there's not a lot of guidance from CMS in this arena, but they have begun to establish some talking points and maybe what you call high-level criteria. And this is for alternative services in general. So what they've said is, do these in lieu of services actually save money? That's the first question. Then they ask, are these in lieu of services part of some larger quality or care management strategy? The third piece is they ask, do these in lieu of services actually improve quality and health outcomes? And then the fourth criteria that they've said in the past is, but much more focused now on these new managed care rules is, can the plan document that they meet these criteria and provide the state's actuaries with sufficient info to analyze the appropriateness? I think what is a potential outcome of this is not only does this change the rate setting process to allow alternative or in lieu of services, but it could also ask for or require an alternative Medicaid-specific MLR or report or supplemental schedule, because a lot of these other services are not necessarily allowed to be incorporated in the more traditional MLR calculation. So this is a really interesting area that we would expect to see a lot of comments from our clients.
Great. So we are almost out of time. Before we do the final comments, I need to announce the CLE code. It is K75Z4. That's K75Z4. All right, well, in closing, the comments on the proposed rule are due by July 27, 2015. I would encourage everyone who does, who works in the area and has issues with Medicaid managed care to submit their comments. But I want to open it up to the group. And we'll start with you, Steve. How would you recommend folks go about, regarding the comment process, and what types of comments do you think would be most useful?
Well, I think it's interesting that you see so much explanation as to what are the concerns CMS has and what are the issues that they're trying to address in the plain language summary. And so I would take that cue, and if you're going to submit a comment, say, look, here's your concern, here's an alternative way to address it, and here's how it achieves your goal. I think if you can connect that dot for them, especially on the actuarial side, I think it'll be get a much better read if you're able to say, here's how my alternative addresses your concerns and the issues that you've raised.
Yeah, and just kind of building on what Steve was saying, as I think we mentioned before, this is a really comprehensive vision of what CMS wants. But prior to that, and over the course of many years, states and stakeholders have pursued and developed their own goals and mechanisms for achieving those goals. And I would say that to the extent there's a practical impact on what they're doing currently, or if there's some ambiguity on the proposed rules as to how they will be impacted, it would make sense for folks to bring these to the attention of the agency in their comments.
Mark, did you have any closing thoughts about the types of comments to be submitted?
One of the issues that has, I'll say, plagued the plan provider space the last couple of years has been the issue of sequestration. What we're hearing here is not that issue, but a great deal of uncertainty about how things will play out and who bears the risk of loss in the event the state doesn't get it right will obviously be an issue to be addressed between the state and the plans. And similarly, the providers will need to make the case that whatever goes on between the state and the plans, not their problem. That the providers are entitled to get paid for the services in accordance with their contracts, and during the course of the year they spend the contracts, and they don't have the build-up capital in order to withstand what I'll call foul-ups. Now, I think we're going to see that issue erupt in this setting as we've seen it in others, as I mentioned, sequestration.
Okay, great. So it looks like we're just at the end of the hour. I did receive some interesting questions, but I don't want to start answering them and not know if the people who asked them are still on the line. So I guess we will be following up with questions after this call. If you have a question you haven't submitted, please do so, or you can always contact us, and our contact information is now on your screen. So thank you, everybody.